So hi guys, this is your quiz number 578. So if you look at this question, here you have a male who is suffering from the head trauma. Then there is a noise in the head, we have chemosis and we have pulsatile proptosis. Now basically I'm not interested in the stuff which is given ahead, though I will explain you, because we have completed the triad that is required for the diagnosis. Actually this is PCB. What is this PCB? See, P for pulsatile proptosis. We have P for pulsatile proptosis. Then C for chemosis. And then we have B for brew. Whenever you have pulsatile proptosis, so at your level, always remember about the keratico-cavernous fistula. Chemosis is the edema of the conjunctiva and brew is the noise in the head. This triad is actually called as the Bandy's triad. So this Bandy's triad is ultra important for the diagnosis of keratico-cavernous fistula. Whenever you are getting this triad, you are sure that this is a case of keratico-cavernous fistula, especially when you have a history of trauma also. Now you can see the things. We have diplopia in the lateral gaze. Cavernous sinus mein, what is the nerve in the center? In the center we have 6 nerve and 6 nerve is supplying lateral rectus, and therefore we have the diplopia in the lateral gaze. Ptosis can be there. Then because you know it's a fistula, where we have a connection between the cavernous sinus and the internal carotid artery. So the blood will flow from a pressure of high pressure region to a low pressure region. So it will go from the artery to the sinus, and that is why we have venous dilatation, tortuosity, congestion, all these things, optic disc swelling, venous dilatation and hemorrhages. That is why the answer to this question is C, keratico-cavernous fistula. Now you can have the same features in the cavernous sinus thrombosis, but you will not have pulsatile proptosis, you will not have history of trauma, you will not have the noisiness in the head. Rather you will have the features of diplopia in the lateral gaze, you will have chemosis can be there, congestion can be there, but there you will have the different risk factors. You can have the orbital cellulitis, you can have acute ethmoidal sinusitis, then you can have the infection in the dangerous area of the face. Now why it cannot be a case of orbital apex syndrome? Because if you look at the apex of the orbit, see, if I think about the apex of the orbit, there I have got two things. One is your optic canal, and second is the superorbital fissure. Now optic canal has got the optic nerve. So if I have the involvement of the optic nerve, there I will have a problem of visual acuity also. But here they have not mentioned about the vision loss. So that is the basic difference between the involvement of the optic nerve in cases of the orbital apex syndrome. Then you have got next one, Tolosa-Hunt syndrome. Tolosa-Hunt syndrome may we actually have the granulomatous inflammation. So if we are having the granulomatous inflammation of the area which is around the cavernous sinus, then that is actually called as the Tolosa-Hunt syndrome. So I hope actually the basic thing is how to differentiate between the cavernous sinus thrombosis and the keratico-cavernous fistula here, and that is very clear. What are the difference in the risk factors as well as what are the differences in the presentation. I hope you have understood it. For any queries you can always directly comment in the comment section of this video, as well as message me on Insta, on the Telegram group, Facebook group, or any other social media that you want. Thank you and happy ophthalmology.